Kia ora tātou, everybody. Welcome to this Goodfellow seminar. Bruce Arrell's my name. I'm the director of the Goodfellow unit. And this webinar has been supported financially by the ARCOS study, and you'll be hearing a little bit about what the ARCOS study involves. But our two speakers, our main speaker tonight is Professor Alan Barber, who's a professor of clinical neurology at Auckland University, working as an active clinic, has set up a stroke unit at Auckland Hospital, and one of our favourite Goodfellow speakers. Our other speaker who will be speaking just a little bit about the ARCOS study is Professor Valery Feigin from Auckland University of Technology, also a practicing neurologist and an epidemiologist and the principal investigator of the ARCOS study. So Alan, without further ado, if you'd like to start your presentation.
Kia ora, everyone. Thanks for the opportunity to come and talk. I always enjoy these talks. I'm a stroke neurologist, but most of my practice is general neurology. But I lead the stroke service at Auckland City Hospital. Stroke's a major problem, as I'm sure you all know, with about 10,000 strokes in New Zealand per year. So it touches all of us. I'm going to give an update about acute stroke therapy and then pause. I want you to ask questions as we go through. Then I'm going to do some secondary prevention cases after Valery's given an ARCOS advertisement and talked about the ARCOS study. And then someone just pulled the plug on me when we ran out of time. So 77-year-old man, last seen well at 10:30 in the morning. His wife, who had been out shopping, came home, found him at 3:30 with a dense left hemiplegia, like no movement down the left. He got to hospital a little bit later at 6 o'clock in the evening, had a scan, got sent back for a CT angiogram and a CT perfusion study an hour later. So we take the last known well time as when we start the clock ticking for treatment, although the use of CT perfusion is means that we can also see how much tissue is left. This is a scan 7.5 hours after last seen well. The plain CT scan, I can't see anything on that. So at 7.5 hours, there's still no infarction, which is great, despite having a significant clinical deficit. This is the CT angiogram. This shows us the arteries. And if you look here, this is one middle cerebral artery. This is the other middle cerebral artery, which ends abruptly there. Can you see that? If you look at the brain the other way, this is one nice, smooth, juicy middle cerebral artery, and there's none on this side. So there's a major clot causing this man's stroke. This is 8.5 hours after he was last seen well. This is well beyond the thrombolysis window. It's actually also beyond the standard clot retrieval window, but this is CT perfusion. We're doing this on all of our acute strokes in the Auckland region now. This basically shows us tissue at risk of infarction. You can see that big blue wedge there. That clot is causing reduced or no perfusion to this area of the brain here. It stopped working, and unless you do something, it's going to die. This scan here is the cerebral blood volume. This shows you brain that's already died. And so you put these two in your mind's eye, so big perfusion deficit, small infarct core, all of this tissue is at risk of infarcting, but hasn't yet died. And so what we want to do is we want to treat a patient when the infarct core, this red area here, is small, rather than wait over the next hour or two for it to get to the full extent. So this is the perfusion deficit, the penumbra. The infarct core with time gets bigger and bigger, and the person's losing about 2 million brain cells a minute. And we want to treat down here when you've got the most brain to salvage. Up here, it's all over. This is beyond the clot, beyond the alteplase window, or the synectoplase window for Christchurch. This is a solitaire stent retriever. It's like a little chicken wire. You feed it into the middle cerebral artery up through the femoral artery. You go through the clot, and then you unmesh it. You you pull this blue sheath out and the chicken wire opens up and it enmeshes the clot. We used to use corkscrews, little micro corkscrews, but what happened is you'd end up pushing the clot further downstream and you couldn't get it. So, and then this is the stent fully retrieved, and then you pull and suck. This is the patient. You can see the guide wire here in the angiogram. This is the internal carotid artery, anterior cerebral artery, middle cerebral artery stops abruptly, and this huge wedge of most of one half of the brain isn't getting any perfusion. So that's the before, and that's a minute later after the stent's been deployed. The artery's been open, the blood flow's been restored. There'll be a dead core here somewhere, but most of this brain hopefully has been salvaged. This is the clot. Isn't that impressive? This is a thumb, so it's at least a centimetre long. This is basically a cast, a thrombus cast of the middle cerebral artery. And it's not a surprise that alteplase that you give into the vein is going to dissolve something like this. So this is why clot retrieval works. This was pulled out on a single pass. We didn't actually use the chicken wire, we just basically went in and sucked. This is the man 48 hours after the scan. And to be honest, I can't actually see any infarction. This is a little bit of staining of the contrast, the dye we squirt to know so the radiologists know where they are. And there's not actually any infarction there. And well, he went home the next day, 72 hours, normal. So this is the sort of treatment that we are doing at the hyperacute stage. So acute stroke therapy has changed significantly. Treatment is time dependent. You know about the alteplase window of 4.5 hours. In fact, with CT perfusion, we can push that out to 9 hours. We can now treat people with wake-up stroke using CT perfusion to show salvageable brain. We don't treat people if the infarct core is already too big. But treatment's still time dependent. There's no age restriction. Our eldest, we thrombolized someone last week who was 98, but a really good 98, completely independent, plays golf. Whereas someone who's in their 60s or 70s with multiple comorbidities we may not treat. So it's really important to get people to hospital as soon as possible. If they call you, just get them to call an ambulance. If you see them, call an ambulance. If they've got neurologic symptoms and signs, they're not having a TIA, they're having a stroke, get them to hospital straight away. Happy to take any questions you've got about the acute stroke therapy side. I'm going to do secondary prevention next, but if you've got any questions, Bruce, I'm more than happy to answer them.
Yes, people can put their questions into the Q&A box. There should be, you should have an option on your screen where you can type in a question. So as they come in, I will ask our speakers. So feel free to ask. Alan, can I say, is there a particular type of stroke that you would do this for, or can you do this for all strokes?
No, you can only do it for the people with the clots, the big clots. So the internal carotid artery clot, the middle cerebral artery stem, the basilar artery. So these are the large artery. These probably about 30, ARCOS will tell us how many people, probably about 30% of the stroke patients. We're currently doing clot retrieval on around 10% of all ischemic, of all ischemic stroke patients in Auckland. It's one of the higher rates in the world. You can't use it for the little strokes further downstream. So the ones, you can't, the catheters at the moment aren't big enough to get beyond around here. Okay? They will, but just at the moment, we've only been doing this for 5 years. They're not good enough. They're not, to get that far up the arterial tree.
We've already got some questions, Alan, if you'd like to take some.
Yeah.
So somebody just says, amazing, thanks for this case. It is mind-blowing, isn't it? Less fearful of old age now. What DHBs are offering this therapy? Well, you mentioned the other day when we were talking, they will fly people in.
Yeah, so this truly is amazing. So this is the biggest thing in neurology ever, I think. So around about 56% of our patients go home, they're independent. And these are the biggest strokes, ischemic strokes you can have. You know, you're clotting off your basilar artery or your internal carotid or your middle cerebral artery. These cause the biggest strokes. And previously, maybe 70% of these patients would die, and most of the rest would end up, or many of the rest would end up disabled. And so half of our patients are going home, and they usually go home within a few days. If it works, it works.
So which centres, if one's in Auckland, perhaps, would you send to one hospital rather than the other?
Yeah, so this requires a huge amount of collaboration. The ambulance services, if they scoop up a patient after hours from outside of the ADHP, because we do it all at our Auckland City Hospital. If they pick them up from the Middlemore catchment area after hours, the ambulance officers will telephone the on-call neurologist, and we'll get them to bypass. So we send people from the Auckland metropolitan region to Auckland City Hospital. We fly about 30% of our patients in from Northland and the Midland region. So from Waikato, Tauranga, Lakes, Taranaki. We've had in the last year half a dozen people from Wellington and Hawke's Bay. The other centres that do it, Wellington does it, and Christchurch is very active. So we're very active. Christchurch is very active. Wellington's getting its service up and running and improving, and Waikato has a business case in front of the ministry coming up to develop a service in the Waikato.
Do they do these perfusion scans before they fly them up? Can they do the perfusion scans locally?
Yeah, so if someone is in the Auckland metropolitan region, if they're at Middlemore Hospital ED, we just bring them across. It's 15, 20 minutes. Yeah. If they're within 6 hours, we just treat. It's for people who are at 6 hours and beyond who want to extend the window, and we can treat people up to 24 hours if they've got a penumbra, that we use the CT perfusion studies. If someone's coming from Waikato and it's going to take probably 90 minutes to get them up, you know, by the time the helicopter gets going and everything, it's probably 2 hours, and they're sitting at 5 hours, we'll get a CT perfusion beforehand.
And so this is a radiologist being awake in the middle of the night now, not the neurologist.
Well, the neurologist screens them.
Right.
Now, this little green scan is not difficult to read. This one here, it's not, you know, I can read that in the middle of the night. And if it's all over, if it's looking like one of these red ones, then I won't even call the radiologist. So, yeah. There's also automated ways. There are programs that will automatically read these scans. It's just that our hospitals won't pay for them. But anyway.
When referring to Auckland Public Hospital, do we speak with the med-reg, neuro-reg, or is there a specific acute stroke review service?
So for the Auckland counties and Waitemata all have their own stroke services. Valery works in the Waitemata one. During office hours, you call the local stroke team. After hours, if you're worried about stroke or TIA, you call the on-call neurology team. So we provide after-hours care for the Auckland metropolitan region for stroke.
All right, question here. Do we still do decompressive hemicranectomy?
Yes.
Someone with a large MCA infarct?
Yes, but you know what? The numbers have reduced because we're not seeing these large MCA infarct. I can't remember the last time we did a hemicraniectomy, because these are the patients who used to go on to get hemicraniectomy with a malignant MCA syndrome, with a clot right down the base of the arterial tree, causing infarction of the whole territory. So yes, we do, but not very much.
What's the role of aspirin or Plavix immediately when you've got a stroke patient? Can you still give those?
We give aspirin and well, I'll wait for the next slides.
Okay, we'll carry on then, Alan.
Okay, well, I'm going to hand over to Valery to introduce the ARCOS study.
Okay. Well, I'll just do a little introduction of Valery. Valery is an internationally very famous professor at AUT, and this is the 5th ARCOS one. I was just starting my first 6 months in general practice when ARCOS 1 started. I had to confess to these two gentlemen that the only patient I had who was eligible, because it was about heart attacks and strokes back then, was that I failed to refer somebody to the ARCOS study. So I didn't do very well, but most of these patients are picked up in hospital, and Valery will just mention briefly what we can do to help the study, because this is a really important international study. It's population-based and it's tracking the changes in stroke management. And with Alan's magic bullet, I think we're going to see some very interesting changes in the next few years in terms of stroke epidemiology, because it's one of the leading causes of disability adjusted life years. So it's an important thing. Valery, over to you, sir.
Kia ora, good evening. Thank you, Bruce, for your kind introduction. I would like to say a very few words about the ARCOS study. And ARCOS stands for Auckland Regional Community Outcome Stroke Study, and how we would like GPs to be involved in this study. GPs have always been involved and extremely helpful across all previous 4 ARCOS studies, and I hope we will have the same support from GPs for our 5th ARCOS study. We just started this study from September 1st this year, and it will last for 12 calendar months. As you can see on the slide, the catchment area for the study is Greater Auckland region. It's a very big region. Initially in 1980, 81, the population of Auckland was just 800,000 people. Now we have 1,600,000 people. So you can imagine the amount of work that comes with this study. And unlike previous ARCOS studies, you're also capturing not only acute new strokes, but also transient ischemic attacks, TIAs. Next slide, please. What we are aiming to do and have to do with ARCOS study is to register all new and recurrent stroke and TIA cases for 12 calendar months until August 2021. And as Bruce and Ellen already alluded to, these data are the backbone actually for healthcare planning. We can estimate even the number of radiologists or vascular surgeons that require to help stroke patients and acute cerebrovascular disease patients with surgery and other procedures, rehabilitation services. Everything comes from this population-based study. And the idea of the population-based study is to register not only hospitalized, but also non-hospitalized stroke and TIA patients for different reasons. In the last ARCOS study, for example, we found that about 1/3 of TIA patients have never hospitalized, although they should be hospitalized as soon as the cases arise, as Ellen already mentioned. So we urge you for urgent referral of all suspected cases of stroke or TIA to hospitals as soon as you see the patient and even suspect stroke or TIA. This study is absolutely crucial to untangle deficiencies in the diagnosis, pre-stroke management for stroke prevention, and post-stroke management for prevention of complications of stroke and occurrence of recurrent strokes. Next slide, please. Next one. So you don't need to worry about people with stroke or TIA who have been hospitalized. If you refer them to the hospital, we will capture them through the hospital system. But what we particularly keen and ask you to support us is to notify about any non-hospitalized stroke or TIA patients, including patients in rest homes, private hospitals, and those Auckland residents, because the study is limited to Auckland residents only, who develop stroke and may be hospitalized for stroke or TIA while they've been outside of a Greater Auckland region, even overseas. And for that, for all these cases, or if you have any questions about stroke patients for the study, you can email us on the email shown on the bottom of this slide. It is easy to remember, ARCOS, the name of the study, and then usual ending of AUT University emails, all emails. So please help us with this important study. We count on you, and the study will be of help for you as well. Thank you.
Yes, so some key points there. People who won't be captured automatically by the study will be the rest home patient, the private hospitals, and if a patient of yours has a stroke overseas, they're the ones they really want to see. So that's that's really important because they won't be captured amongst the hospital admissions. So thank you, Valery. So arcos@aut.ac.nz. Back to you, Alan.
Right. Well, I'm going to talk about secondary stroke prevention, and I'll stop it at about 8:30, or unless you get bored, just cut the slides. So 73-year-old man, 3 episodes over the last couple of days of left-sided weakness and sensory loss down the left side of his body. Each episode lasting for 2 to 10 minutes. Hypertensive, diabetic, smoker. Okay, so this man has had 3 TIAs. TIAs last around 10 minutes, plus or minus. If people have symptoms that last longer, if you do MRI scans, you've got a good chance of seeing an infarct. If the patient has managed to get to your practice and they've still got even subtle residual symptoms, they're not having a TIA, it's likely they're having a stroke. With these 3 episodes over the last couple of days, can you tell me what's going on? So for those of you who are quick at typing, what do you think's happening to this patient? Why is this patient having 3 TIAs? Any takers?
I think we've got an answer here, Alan.
Yep.
AF?
AF, certainly AF causes recurrent problems, but this patient's symptoms are exactly the same, left-sided weakness and sensory loss. If you've got a clot in your heart that's throwing off little emboli, they can go anywhere in the body. And for them to go to exactly the same part of the brain 3 times over 3 days is a little bit unusual. AF tends to cause symptoms here and then symptoms on the other side rather than the stereotype thing. So it's worth thinking about AF, but this particular case isn't.
Unstable clot in artery?
Unstable, yeah, this exactly right. This patient's got an unstable plaque, okay? And in fact, these are called crescendo TIAs. Yep. TIA after TIA after TIA, and sorry, I've lost my slides here. Can you see my slides?
Yep.
Okay, TIA after TIA, and then what ends up happening is the patient ends up having a stroke. They are crescendo TIAs. They're usually restricted to the internal capsule, and you get face, arm, and leg symptoms. And what happens is one of these. This is the basilar artery. These are the 2 vertebral arteries. This is the middle cerebral artery stem. These are the ones we go into here in the basilar artery to pull out the clot. These little lenticulostriate vessels penetrate the substance of the brain, and they supply a small area. So there's a little atherosclerotic plaque going on here, and so you get ischemia in this isolated part of the brain. Isolated, but it's in the internal capsule. This is the patient. So the man came in because he'd had 3, we did an MRI scan. You can already see there's a little infarct on the DWI, on the diffusion weighted image. Can you see that? So even though this man is currently normal, he's had a little infarct. So that's the next point I want to raise, is that we now call patients with transient symptoms, a TIA, who has infarction on their scan, we now call them a stroke and not a TIA. So do you understand that? So, and that just reinforces that TIA and stroke are the same disease. They're part of the same spectrum. And so you can have transient symptoms and no infarction, a true TIA, or you can have transient symptoms and infarction like this patient, or you can have infarction and a stroke. And so we now call transient symptoms with infarction a stroke. This patient was, because of the crescendo TIAs, we take it really seriously. And we started him on treatment, but in fact, we started on IV heparin, but he still went on and infarcted. And so this is 4 days later. So this is a subsequent infarct, not just expansion of this one. So that's why we take crescendo TIAs seriously. And this patient had a little atherosclerotic plaque or lipohyalinosis in the olden days at the origin of one of these little vessels, and it finally gave up the ghost. Any questions about that? I'll talk about how we treat it, but any quick questions?
None at the moment.
Okay. I'm a fast talker.
Yep.
So how do we treat it? So this gets me onto secondary stroke prevention. So if someone's had a TIA or a stroke and they're in sinus rhythm, we use antiplatelet therapy, pretty much for everybody. Okay? If they've had a hemorrhage, we don't. But if they're an ischemic stroke or a TIA, we use antiplatelet therapy. If they've had a TIA or a minor stroke with minimal symptoms, we use aspirin and clopidogrel together for 3 weeks, dual antiplatelet therapy, and then we stop one after 3 weeks. We usually stop the aspirin, but you can stop the clopidogrel. So we use 2 antiplatelet therapies for 3 weeks. So there have been recent studies, the CHANCE study, big Chinese study, and the POINT study, which we took part in, showing that this is that we use dual antiplatelet therapy. Okay? However, after the 3 weeks, you have to stop one of those antiplatelet therapies, because earlier studies showed that the use of dual antiplatelet therapy beyond 3 weeks becomes harmful. So for the first 3 weeks, it's beneficial. After 3 weeks, it increases your rate of hemorrhage. Okay? If it's a disabling stroke, then you use one of these agents alone. So you only use the dual antiplatelet therapy for minor stroke or TIA. Okay, so you might get discharge summaries saying DAPT for 3 weeks, then stop one. That's what this is about. Okay, and again, I'm happy to stop there. I've got another case. If there's any questions about anything I've talked about up until this point, happy to answer any questions, Bruce.
No, we seem to be fine here, Alan. Carry on.
Okay, so this is another patient, 64-year-old man, sudden onset of weakness in the intrinsic muscles of his right hand. So very, very localized to his finger flexors and extensors, and it was very disabling for this particular patient. He was otherwise normal. So suddenly his right hand stopped working. Hypertension and a bit of a stress in his life were the only other risk factors. This is his scan. This is a diffusion weighted scan here. In fact, it's a very old diffusion weighted scan. This is the T2 weighted scan. So look at this. You know, when you're looking at scans, always look for the arrows. They're usually a clue. And you can see this patchy infarction here. This is the central sulcus. So this is right on the hand area of the brain. It's called the hand knob. And this patient has a cortical hand. And this is pretty rare stuff, but it's just interesting. It can cause a very focal deficit. It can mimic a radial or ulnar neuropathy. In fact, you know, the reason why this man got a scan was because we couldn't figure out if it's a sort of if he had an ulnar and radial neuropathy or if it was a stroke. And so it's not that uncommon, but it's, you know, it's sort of neurology stuff. But what caused this man's stroke? For the more observant of you out there, what do you think the mechanism of this man's stroke was? Because by knowing the mechanism, you can prevent it from happening again. Significantly, you can significantly reduce the chance of this man having another stroke. I'll give you a clue. Why do you think this man had a stroke?
Emboli?
Yeah. Where from?
We're going for honours here.
Yeah.
Where are the emboli coming from, folks?
Yeah, where are the emboli coming from? And if you understand this, you understand.
From the heart?
Exactly.
Yep.
And the reason why was there was another arrow. And so these DWI lesions stay bright for about a week to 10 days, and then they disappear. Okay? And then you'll see the stroke on this scan, the T2. And so there's a little embolus here, a little embolus has gone here, another one. And this is what I was saying. Atrial fibrillation, the emboli can go anywhere. They can go into your hands, they can go into your gut, they can go into your brain. And they can go, this is two different hemispheres. Clots come from a proximal source. It hasn't come from the neck because an atherosclerotic plaque rupturing and causing emboli, still only one hemisphere. So it's come from the heart. This patient was in sinus rhythm, had no cardiac symptoms, had no cardiac history. And so we put him on telemetry for more prolonged monitoring. And he was flicking into and out of atrial fibrillation. He didn't know about it. No one knew about it. And it was only because of the scan seeing emboli into hemispheres that the penny dropped.
And an interesting thing that's come out of ARCOS was a certain number of people who had strokes had atrial fibrillation that had been anticoagulated.
Yeah, I've got a couple of slides on that.
Okay, go for it. Yep.
So the point here is that paroxysmal atrial fibrillation comes and goes. Patients don't always know about it. It carries a similar stroke risk to permanent atrial fibrillation. So that's a really important point. So PAF, paroxysmal atrial fibrillation, is as bad as permanent atrial fibrillation, okay, in terms of stroke risk. And in terms of secondary stroke prevention, all ischemic stroke and TIA patients who've had if you've had a stroke or a TIA and you're in atrial fibrillation, you need to be on anticoagulant therapy. Your chance of having another stroke in the next year is about 1 in 10. That's a big risk. And by anticoagulating the patient, you can drop that risk by 2/3, from about 10% to between 3 and 4% in the next year. It doesn't reduce it to 0, but it reduces significantly.
It's worth saying there's not many things in primary care that have that big benefit in that time, is there?
That's exactly right. That's exactly right. But the problem is, until recently, we just had warfarin, until not that recently. But now we've got dabigatran, a direct thrombin inhibitor, rivaroxaban, apixaban. If you want to get honors, it's the XA that tell you it's a factor 10A inhibitor. And dabigatran, that's our standard here in New Zealand. It's not elsewhere in the world. They have access to other ones, better access, but this is the one we use. 150 twice a day for most people. If someone's got impaired renal, moderately impaired renal function, or they're old, we'll drop it down to 110 twice a day if you're worried about bleeding risk, because the 110 twice a day dose carries less bleeding risk than the 150 milligram twice a day dose. The good thing about dabigatran is we can reverse it. We routinely have stroke patients come in who are taking dabigatran, or usually, as you're about to see, they forgot to take their dabigatran. They have a stroke. We reverse it with this agent called idarosizumab, which we keep in the ED department with our thrombolysis kit. We reverse it, and we reverse their anticoagulant, and then we thrombolyze them. Okay? So that's one of the advantages of dabigatran. But we also use rivaroxaban. This is good. You give it once a day. It's good when compliance is a problem. And I'd have no problems with any of you changing a dabigatran patient over to rivaroxaban if you thought that a once-a-day solution is better for the patient. It's also better because you can't put dabigatran in blister packs. And rivaroxaban is also good when the creatinine clearance is really low. You can take it right down to quite significant renal impairment. So that's when we would use rivaroxaban. Type in your questions. Seriously, I'm more than happy to answer anything you want. As Bruce alluded to, the last ARCOS study put us down this track. About 30% of our stroke patients, ischemic stroke patients, were in atrial fibrillation. That was up from about 20-25% in the previous ARCOS study. So the number of patients with stroke and atrial fibrillation are increasing. I mean, atrial fibrillation is increasing in our community, but also the share of ischemic strokes as a result of atrial fibrillation and those emboli coming off is also increasing.
Is that increasing because of aging, or is the absolute rates going up, do you think?
In terms of patients are aging, and so they're living with other cardiac problems and the atrial fibrillation is coming about. We're better at looking for atrial fibrillation now. So all patients with ischemic stroke now go on telemetry for at least 24 hours, at least. And so we're seeing it more frequently.
Yeah.
But just to go through with atrial, the big problem we've got with atrial fibrillation is undertreated. And it's not just a New Zealand problem, it's a worldwide problem. So this is an audit done by Arundam Carr, who's the lead stroke physician at Middlemore Hospital and one of his registrars. They looked at all of the stroke and AF patients from the 1st of January to the 30th of June this year. So first 6 months of the year. All their stroke patients come into Middlemore Hospital with AF. So in the first half of the year, they had 364 ischemic stroke patients. They had another probably 50 intracerebral hemorrhages. So they're looking at 400 patients per 6 months, 800 stroke patients at Middlemore per year. Big problem. 20% of their patients came in with known AF. 8% of their patients had newly diagnosed AF, and 72% had no AF. Okay? So around, working at a moment, 100, 110 patients had AF either known or diagnosed out of their 364 patients, a quarter of them. Of the 74 who had known AF, 71 had a CHA2DS2-VASc score of 2 or more, which is what the cardiologists tell us should be anticoagulated. So 71% should have been anticoagulated. Sorry, 71 should have been anticoagulated, but a third weren't. And Arundam went back and looked at the reasons why the patients weren't anticoagulated, and there were no good reasons in 20 of them. There were good reasons in 3 of the 20, but there were no good reasons.
Alan, the question here, is there an age limit where the risks of anticoagulants outweigh the benefits?
No, there's not an age limit, but again, you have to use your clinical common sense. So there's no age limit, and the stroke risk is significant. So if you've got someone who's 85 and their CHA2DS2-VASc score is 6, that's a significant stroke risk. And their risk of an ischemic stroke probably far outweighs any risk of bleeding, particularly with these newer agents where hemorrhage is less. Okay, but again, use your common sense. So, and it's not always easy. So I wouldn't categorically say this person's 85 or this person's 80, I'm not going to anticoagulate them. Look at the patient. Are they driving a car? Are they delivering meals on wheels? Do they have a good quality of life? And then discuss it with them. Of the 48 patients who are actually taking anticoagulants, who had known AF, 32 were on dabigatran, which is the one we use the most. 10 are still on warfarin. So if someone's stable on warfarin, they've been on warfarin for years, it's okay to leave them, okay? You don't have to change them to one of the new ones. 5 were on rivaroxaban. Of the 10 patients taking warfarin who came in with known AF, 9 were subtherapeutic. So 10 patients on warfarin, and 9 of the patients it was useless because they weren't taking it properly. Of the 32 patients taking dabigatran, 46% actually weren't taking it, because we can measure by the direct thrombin clotting time if they've got it on board. And you take dabigatran twice a day. If that's low, they didn't take it that morning or the night before. When Arundam went back to the patients, 9 of them confirmed they weren't actually taking the medication. And 2 of the patients, the surgeons had withheld the dabigatran for surgical procedures. This is a big problem. And I'll show you how to get around it in a minute. And a bigger problem is they get stopped it, the patient gets discharged from hospital, and they forget, the house surgeon or the surgeon forgets to tell them to start taking their dabigatran again. So at Middlemore, of the 71 patients with atrial fibrillation who came in with an ischemic stroke, just over half of them were either not prescribed anticoagulants when they should have been, or were not taking them appropriately. These 40 strokes, almost all of them could have been prevented. And that's just Middlemore Hospital over a 6-month period. I'm sure my hospital's no better, North Shore's the same, Waitakere Hospital's the same. So, you know, that's probably 150 strokes that many of them, at least 2/3, probably more than that, could have been prevented had these patients been taking an anticoagulant. You're on mute, Bruce.
Alan, are we able to check to see if our patients are taking their dabigatran in the community with that blood test, or is that a hospital test?
I'm sure you can ask for a direct thrombin clotting time. Direct thrombin clotting time, APTT, and a direct thrombin clotting time. You can understand patients with warfarin. That was a nightmare. But these newer agents, I guess taking a drug twice a day is a problem, but particularly for patients who don't have AF symptoms, you know, they don't get in the cardiac symptoms and they don't get the palpitations. It's hard, sometimes it's hard for them to realize why it's so important to take, you know, these medications. And so it's really, you're in atrial fibrillation, you've got a high stroke risk, very high stroke risk, and patients do not want to have a stroke. Happy to answer any questions about anything up till now.
Just a question about iron deficiency anemia with angiodysplasia, I presume, in the bowel, in an older group, which makes it hard to juggle. So how do you dance with the anemia versus the anticoagulant?
If someone's anemic, then you've got to be careful about starting an anticoagulant. But that's a good reason to get an urgent appointment with the surgeons. This person is in atrial fibrillation. They have a high stroke risk. The stroke could happen at any time. They have angiodysplasia, or they're anemic and they've got black bowel motions. Please see urgently. This will change management. Angiodysplasia is not going to kill you or permanently disable you. A stroke will.
Bruce, may I answer a couple questions about ARCOS?
Yeah.
Yes, there was a question about inclusion of non-residents of Auckland region. No, non-residents of Auckland region are not included in the ARCOS study, and residency is defined as living in Auckland for at least 12 months. That first question. And second question was, if a TIA happened in Auckland, they are treated in Dunedin, for example, will that patient be registered? Yes, all Auckland residents, regardless where they developed their stroke or TIA within the study period, from September this year till September next year, will be registered, aged 16 plus. We are not registering strokes or TIA in children. And another question or comment is that we will try to contact all GP practices to remind them about the study, the criteria for inclusion and this in the study, and asking them for help.
Look, if in doubt, just refer to us.
Yes, and the referral
figure it out,
can be easily done either through that email or phoning us or Ellen part of the ARCOS study. So we all are very keen to hear from you. That's all.
Carry on, Alan. This is good.
Okay, just as I said, pull the plug when you get bored.
Yep. No,
Okay, so
the questions are roaring in.
okay, so how do you avoid problems? I start people with stroke on these anticoagulants, and I always discuss the risks and benefits with the patients. I lay on the risk of a further stroke heavily because they've already had one. You've got a 1 in 10 chance of having another stroke next year, and that stroke risk continues for the following years. So you want to know when to start, what agent to use, are they old, do they have renal impairment, and what to do. Let the patient know what to do if they develop any bleeding problems. If minor bleeding problems, come and see you. If it's more severe bleeding problems, get straight to hospital. And this is what I use. I use on my iPhone. This is a dabigatran app. Just look up it's on the App Store. Bruce looked it up the other day. And this is specific to New Zealand. It tells you your dose for your patient. You can click on more information about it, how to manage bleeding. My patient needs elective surgery, what do I do? My patient needs emergency surgery, what do I do? And you click on these boxes and they come out, and this is the dose one. Okay, you type in 54, male, 78 kilos. This is his creatinine, the indication for the dabigatran AF. This is the creatinine clearance, which it calculates for you, and it tells you the dose. Consider 110 twice a day dose if he's got gastritis. Okay, so I find that quite useful. So dabigatran app for New Zealand on the App Store. Okay, what's new as secondary stroke and TIA prevention as far as hypertensive therapy is? Nothing. Treat them all. Okay, so the targets have gone. Having said that, I aim for a blood pressure in most stroke patients, in their 60s and 70s, for around 130 over 90-ish. I don't write that anywhere down because it's against the party, sort of you want to get it a bit lower than that, but that's a good blood pressure. 140 over 95 is probably getting up there a little bit too much. So you want to get the blood pressure down. So studies have clearly shown this reduces your chance of further strokes and heart problems. Okay, and we do that for ischemic strokes and intracerebral hemorrhages. We give antihypertensive to normotensive patients, previously normotensive. So basically, if you have a stroke, you end up on an antihypertensive agent. Okay? The only time I don't is when people are fainting from being overtreated. Lipid lowering therapy. All ischemic stroke patients, it's like a stamp we put on as people come through the door. We put everyone on a statin or ezetimibe. We get their cholesterol down. We have a target, which you'll be aware of from the cardiology literature, but this has only just come out for stroke. We want to get the LDL cholesterol down to less than 1.8. Okay? So we'll start people in the hospital on atorvastatin 40 milligrams. If they come in and their LD to see you and their LDL cholesterol's 2.2, 2.5, double the atorvastatin to 80. Okay? Unless there are side effects. There's a number needed to treat of 42. So modest effect, but there are so many stroke patients that if you do this to everybody, you're preventing a large number of recurrent strokes. We don't routinely use statins after brain hemorrhage. We do if they've got high cholesterol. Okay, how are we doing for time? Okay, a couple of more cases. Unless you any questions so far, Bruce?
just one about blood pressure there. How low is too low? This was referring to diastolic. I think the New Zealand guidelines don't comment on that. Do you have a view?
You're not going to find this written anywhere, but until patients start to become, if someone's starting to become dizzy when they stand up, that's too low. But if a diastolic 60 and they're fine, that doesn't worry me in the slightest. Now, of course, it depends varying on the patient. So remember, half of Middlemore patients are of working age who have a stroke. The number's less in North Shore, and it's probably around a third in Auckland, because Maori and Pacific people have their strokes. ARCOS has shown us this. Have their strokes. Maori people have their strokes. First average age of first stroke, I think, is 56, compared with Europeans at 72. We know this from ARCOS, and so we're more rigid for the younger patients than we are with someone in their 80s or something like that.
Alan, do you have a favourite electronic tool for demonstrating to patient the risks of their future stroke versus bleeding risk?
Well, Valery has got a great tool. Valery, maybe you want to plug this.
Yes, our university developed a stroke riskometer app, which is free to use and download, and it shows the risk in absolute and relative terms, and also provides recommendations for a primary stroke prevention based on the user's profile of risk factors. So it's been endorsed by all major international organizations, including World Stroke Organization, World Heart Federation, European Stroke, many national stroke organizations. And it's relatively easy to use. It is already available in 13 languages. And I can show the...
What's the name of it, Valery? How's that spelled?
Stroke riskometer.
Stroke riskometer app.
Yeah. It's very cool. And patients can do it, or you can do it, and it'll give the patient in front of you with a stroke risk.
Yes, and it's available for Android smartphone and Apple phone.
Yeah, so
tablets.
Just look up on the internet, stroke riskometer.
Easy to download.
It's world famous.
And there was, I'll just get this question, otherwise I'll lose it. About registering patients. Oh, hang on.
I've got a couple of slides in a couple of minutes about.
Okay. Well, what about consent for the study? Will patients be interviewed or their notes only?
Valery.
For ARCOS study, we register all patients from medical records, and we require patient consent only for follow-ups, for asking them specific questions. Otherwise, all the information is taken from medical notes.
So we have ethics approval to do that.
Yeah.
Yes, we have ethical approval, HDEC approval, and AUT ethics committee approval for the study.
I've got 2 one-minute cases, Bruce.
Go for it.
These are just sort of 53, these are just spots, so get fast on your typing. 53-year-old man, 4 days of mild left neck pain, then sudden onset of right hand clumsiness. Okay, left neck pain, right hand clumsiness. He looked in the mirror and saw this. So this is him. What's this? What's going on here?
Anybody want to hazard a guess there?
Describe what you're seeing.
Horner's syndrome, Tosa.
Horner's
with vertebral artery dissection, Horner's, third nerve palsy, Horner's.
Well, let's have a look. So there's some pretty smart people out there. So this is a partial ptosis. Third nerve palsies are often all or nothing, and you often get a complete ptosis. And see the pupils? This pupil's smaller than this pupil. Oops. And so the partial ptosis and a small pupil on the same side, meiosis, is a Horner syndrome. This man has a Horner syndrome. He's got pain in this is the left eye, and he's got pain in the ipsilateral neck. And someone said dissection, it's actually an internal carotid artery dissection. You can get Horners with a vertebral artery dissection as well, you can. But you often get other brainstem problems as well. And so this man has a vertebral artery dissection. Sorry, he's got a carotid artery dissection. And these people present with ipsilateral neck pain, ipsilateral Horner syndrome, and contralateral stroke symptoms and signs. And we treat these with dual antiplatelet therapy for 3 months. If they're having recurrent episodes of brain ischemia, we give them heparin followed by an oral anticoagulant. So that's just sort of if you want to be clever, you know, neck, Horner syndrome, dissection. And if they've got contralateral opposite side, brain symptoms and signs, they've had a little stroke. So this man had a little stroke. And the last 1 minute, because I said I'd finished at 8:30, 46-year-old woman, hypertensive ex-smoker, sudden onset of right hand tingling. Over the next 5 minutes, it spread up to involve the whole right upper limb and face. And then 10 minutes later, she struggled to get words out. What's going on? So hand tingling, arm and face tingling over about 5 minutes, and then she can't get words out.
Got migraine as one suggestion, Alan?
Yep, that's exactly what's going on. This is not a stroke or a TIA. This is a migraine. That march of symptoms is called a migrainous march, and it happens over minutes, and she's become dysphasic. And what happens is you get spreading depression over the brain, and it can start anywhere. It usually starts in the visual cortex, and you get the vision symptoms, you know, the blinding headache. But in this particular woman, it started in the hand knob. We saw that in the brain earlier. And then the cortical spreading depressions spread up the arm area of the brain and then to the Broca's area of the brain. So that's a migraine. It can be difficult to distinguish from TIA. TIA or stroke, sudden onset, you get struck down, migrainous march, symptoms come on over minutes, okay? In fact, she went on to develop a low-grade headache. What happens with these patients is that the neurologic symptoms are so scary, because you can get weakness as well, that the headache gets lost. People are so worried about not being able to move their arm or feel their arm that they forget about the low-grade headache. In fact, this woman had headaches at school and with her periods, and her mother's got migraines, and this woman had migraines. If you're not sure if this is a TIA, send it to us, to ARCOS. So to summarize, if a patient has neurologic symptoms when you're seeing them that came on suddenly, it's a stroke. There are time-dependent therapies. Call an ambulance. Don't let the patient go home to get their pajamas and their toothbrush, okay? Which happens because they turn up after they've had a shower and got their hair done, and it's a nightmare. If you've got transient symptoms that come and then disappear completely, but we see infarction on the brain, we're going to call it a stroke and not a TIA. If a stroke, ischemic stroke or TIA patient's in sinus rhythm, and it's a minor stroke or a TIA, we give them dual antiplatelet therapy for 3 weeks, and then we stop either the aspirin or the clopidogrel, and we don't continue both, we just continue one. All patients with AF or paroxysmal AF who have had an ischemic stroke or a TIA, we anticoagulate. For your patients with AF who haven't had a stroke or TIA, do the CHADS-VASc score and anticoagulate them if they need it. Don't talk them out of anticoagulation, talk them into it. By doing this, you could prevent up to 20% of strokes. All patients with stroke go on anti-hypertensive therapy. We aim for a LDL cholesterol of less than 1.8. And just to reiterate, the ARCOS studies, I'm sure you get asked to help in a lot of studies, but ARCOS is the largest stroke epidemiology series of studies ever done. Each ARCOS study is the biggest stroke study ever done. Is that correct, Valery? And certainly with the series of them, this is number 5 coming up.
Yeah, it is the largest and the longest. The competing study with us is Connecticut, Northern Manhattan study by size, but we are carrying out this study for 4 decades, which is only comparable with Oxfordshire stroke study.
So this is 40 years worth of studying, and this is a treasure. It's a world treasure. And the international community want to know what happens. And what happens with stroke studies is everyone does hospital stroke studies. It's easy. But what is different with ARCOS is that we need your cooperation because we identify everybody with a stroke, not just the ones that make it to hospital.
Yeah.
Most people are making it to hospital these days, but not all the TIAs are making it to hospital. And there's still a percentage of people who don't get to hospital. We want to know about them. ARCOS has led to significant changes around the world in stroke service provision and practice. Now, we're going to pick up anyone who turns up in hospital, so you don't have to worry about those. But some people aren't admitted, and these are the ones we're after. So the TIAs or the minor strokes, the stroke that happened 2 weeks ago that you're not going to necessarily send to hospital, the stroke that happened when they were on holiday in Queenstown, not Queensland anymore, Queenstown, and they've come back. Strokes that occur in private hospitals. We are going to the private hospitals, but you know, if you hear about one, just let us know. And patients who die before reaching hospital, we will find them eventually from the death certificates. We go through all of the mortality, national mortality data, but you know, if you can also let us know about them. And that's the website. And if you've got any questions, you can call me. I hesitate to say give me a call, but if you're really unsure.
We've got till 8:45, Alan, and so I've got a question here. Still a bit confused about disabling stroke. Clopidogrel or aspirin dipyrimidol, how do we choose? Okay,
so a disabling stroke is the TIA and minor stroke. These are the people who go home the same day. You know, they come in, they get a scan. We do the CT angiography now. We're not mucking around waiting for 3 weeks for an ultrasound scan of the carotids. It's a one-stop shop. We start the medications, we send them home from the ED. We're not worried. They go on dual antiplatelet therapy. People who get admitted usually have a usually have more disability, and we will sort that out in the hospital. And we use clopidogrel. Aspirin and dipyridamole together are equivalent to clopidogrel, and aspirin is almost equivalent to clopidogrel. It really doesn't matter. We don't use dipyridamole so much anymore because it causes headache, and it's 2 tablets, 1 aspirin and 2 dipyridamole tablets per day. It's easier just to give them 1 clopidogrel tablet.
Any relevant updates on coronary artery disease investigations, imaging for symptomatic TIA patients, when to investigate and to refer to vascular surgery?
Okay, so I'll leave the MI as not being a cardiologist question aside, but for TIAs, we investigate them all. TIAs carry the same adverse prognosis as unstable angina. Okay? A true TIA, I'm not talking about the dizzy-doos. I'm talking about someone with unilateral weakness, sensory loss, a dysphasia, or a hemianopia. If someone comes in, even if the symptoms lasted for 5 minutes, their risk of a stroke, further TIA, MI, or vascular death in the next 3 months is around 10%. That's in the next 3 months. We know that by starting aspirin or anticoagulant or a clopidogrel, starting an antihypertensive agent, starting a lipid-lowering therapy, looking for carotid stenosis and sending them off to the vascular surgeons, we can reduce that 10% in the next 3 months right down to almost nothing, maybe 1 or 2%. Okay? So we take TIAs very seriously, minor strokes. We CT scan them, we do CT angiography. We'll send them for a Holter monitor if we're suspicious about atrial fibrillation. When they come in, we hook them up on the telemetry for a few hours or overnight, and we start the medications before they go home. If they've got a carotid stenosis, we call the vascular surgeon straight away. The really important thing about vascular surgery for carotid stenosis is, one, there's less of it because we're using these secondary prevention medications. And two, if you're going to do a carotid endarterectomy, you have to do it today or tomorrow. Half the strokes that follow a TIA, half the strokes that follow a TIA or a minor stroke, where we're considering carotid endarterectomy, happen in the first 48 hours. Okay? So waiting to get a carotid ultrasound scan at 10 days, most of the stroke risk has already happened because that patient's got an unstable plaque. And after 10 days, 2 weeks, the plaque starts healing. So we take them very seriously.
And I think the thing about the target for the LDL, Alan, is you start to get atherosclerotic reversal, certainly, I think, in the coronary arteries, isn't it? Is that
and in the carotids as well.
Yeah, yeah. So
you get stabilization of the plaque. There can be a little bit of shrinkage.
We're getting on to rate control of atrial fibrillation. Where does that fit into the management of and stroke prevention?
So from a stroke neurologist's point of view, I don't care about the heart. You've got to get the rate under control if they're symptomatic. We call the cardiologists. You need to call the cardiologists. But all of these patients need to go on an anticoagulant. Okay? If they've had
the most difference.
It doesn't matter. You can get the rate under control. They're still going to be on an anticoagulant.
As we were talking before this, I was saying if you're on a desert island, your anticoagulant would be the last drug you would stop if you're looking at de-prescribing.
Yes, that's exactly right. No, it's different for people with lone AF, someone who's 50 and doesn't have any, their CHADS VASC is, nothing. That's a different situation. You've got to get the rate under control. But I deal with people who've had a stroke or a TIA. They all go on anticoagulants. If your CHADS VASC score is 2 or more, or whatever the cardiologists are telling us at the moment, they go on an anticoagulant.
We've got a question about Paul Metabolis here about CYP2C19 function.
Must be a
metabolizers. Is that of anticoagulants? Is that an issue? Or
no? So what we're talking about, we know that Asian people in particular lack a particular enzyme that can convert clopidogrel to a more active form. But in fact, the study that showed us that clopidogrel works, particularly with dual antiplatelet therapy, was in China. The studies that have shown that clopidogrel doing these tests, looking for the enzyme effect, actually hasn't any effect on patients. There's no evidence about that. So, if I had an Asian patient, I probably wouldn't start them on clopidogrel, but at Auckland, we don't routinely test. I think at Middlemore you do. At North Shore you do, but we don't. That's getting really down to the fine nitty-gritty.
Yeah, a hard question. Any dietary recommendations to prevent reduced stroke risk?
Yeah, better diet.
What's a better diet look like, Alan?
Mediterranean diet.
Mediterranean diet, yeah. That's the only one that's been shown to make a difference, isn't it, I think?
Valery, do you have any comments on that?
Yes, you may find quite detailed recommendations for healthy diet in the Stroke Riskometer app, which has different options, different preferences.
You and I, we all know what a healthy diet is, and we all know what a healthy diet isn't.
Yeah, I think the main issue is to motivate people and keep them maintaining their healthy diet over a long period of time. So for that, Stroke Riskometer is a motivational tool. They can monitor their progress. They would know their risk exactly and how it changed with the changes of their risk factors. So it's quite a motivational tool as well.
So they just click on it. They just click on one of the pages in the stroke riskometer. You know, do I need to change my diet? Pops up what you need to do.
Yeah.
This may be a question from Dunedin. What happens in Dunedin Hospital with ischemic stroke? Do they get
you get thrombolized in Dunedin in the helicopter. Well, in fact, you use tenecteplase in Dunedin now, but the patients are helicoptered up to Christchurch.
Right.
It's, you know, we're piggybacked on the cardiologists who've been flying people around for ages. And the helicopters, the Taranaki helicopter takes an hour to get to Auckland. It's amazing.
If having TIAs while on anticoagulation, rivaroxaban in this case, for AF, would you add an antiplatelet agent? This is the...
Yeah, that's rare. That's a toughie. If you add an antiplatelet agent, you're going to increase the bleeding risk.
Because we have this situation with people having post-MI and AF. What to do with them? That's a bit of a nightmare.
We often will, but it's important not to let it carry on.
Yeah.
And that sort of patient, you might be thinking, if they're having recurrent TIAs, is it one of those small vessel TIAs where you do need an antiplatelet agent?
Yeah, yeah. Okay, well, I'll call the show to an end. So I'd just like to thank the audience for coming along tonight, given that we were competing with the leaders debate. I think we'll all go away and have a little, hopefully being recorded. Just to remind you that the email is arcos@auckland.ac.nz. And I'd like to thank Alan for his wonderful presentation, and what an exciting time to be a neurologist, being able to fish clots out of people's brains. I remember when you first talked about that, my eyes just sort of were like saucers. And Valery, thank you for your contribution to science and to keep ARCOS going. It's very important. As you say, it's like a national treasure. Very important to keep these things going. And it takes a lot of work, just getting the money and the funds. You know, it doesn't, nobody comes around and gives you millions of dollars to do this. You have to struggle and fight for it. You've done a terrific job. So great to be able to work with you guys. So, okay.
Thank you.
From us. So
Thank you. Guys.
Folks, you'll be getting a feedback sheet. So I think it's been a great evening. So thank you very much.
Okay. Good night.